Okay, the role of ultrasound imaging in neuraxial procedures. I will show only some procedures, possible procedures. I believe that the procedures on cervical medial branches, diagnostic blocks, radiofrequency ablation or cryo-analgesia, they have a future because we can see the nerves. Then I will talk a little bit about the possibility of epidural and spinal procedures and whether they can help us in difficult conditions or not. Cervical medial branch block. I choose as an example the level of C for 5. You have a transducer position like this, longitudinal along the cervical spine. Then my approach is a short axis approach from anterior to posterior, that when I miss the bone, that I'm not going intraforaminal, that I go into the back, into the muscles. And then, when you are lucky, when you have a good patient, you have a picture like this. You see the articulation, second articulation, the third articulation. This is the articulation C4-5. Then you have here a small nerve, a medial branch of C4, and down here you have a small nerve, a medial branch of C5. In this picture you see that the medial branches are crossing just at the deepest point between two articular pillars. This is what we expect normally. But when you go to real patients, when you want to make radiofrequency ablation, when you depend on fluoroscopy, radiofrequency ablation is that you make a matrix lesion. Usually you make 6 lesions that you are sure that you caught the nerve. What we made here, we were scanning 50 patients and we were looking how far away the medial branches were from our target point. With the fluoroscopy, we want to have the nerve down here at the deepest point, or in a special case of the C2-3 articulation where the third occipital nerve is crossing on top of the articulation. And we measured the distance between this radiological target point and the real nerve. And what we could see is that it's quite good. Most of the nerves are around 0, are here, or here. But what we could see also is that we have a big variation. We have 2 millimeters more cranial, 2 millimeters more caudal, and when you know that your radiofrequency ablation causes just a lesion about 2-3 times the diameter of your needle you introduce, then it can be when you have a nerve like this and when your needle is there that you miss it, you make a radiofrequency ablation and you do not have a good effect. Another thing is when you do it on the site, when you see the nerve, when you bring your radiofrequency probe close to the nerve, you don't have to do a matrix lesion. Usually 2 lesions is enough, and then you bring down your procedure time. Another possibility, again, when you have these small nerves, you can bring in a cryo-analgesic probe. And the good thing about cryo-analgesia is that your ice ball is forming also in front of your needle tip. Then you don't have to bring the needle parallel to the nerve. You can go directly to the nerve, and then you can freeze. And what you see here, that's again this articulation. And here on the deepest point, you see this black ball. And when you freeze more, then you see that you have a bigger black ball, and then all this. That's the ice ball forming when you make a cryo-analgesia, and then you can control whether your nerve is really in the ice ball or not. Another good thing about ultrasound, you see what you do. Now I'm going to central neuraxial blocks, and I suggest that you read this beautiful review article from the Canadian group, Dr. Chin, Philip Peng, and Manoj Karmakar from Hong Kong. They were writing how to do spinal epidural approach, and you will find the normal anatomy in this review article. It published Anesthesiology last year. I show you some of the pictures because I think they are totally clear. When you have a transducer position in relation to the lumbar spine like this, that means your transducer is over these articular pillars here. You have the CT scan, you see the articular processes, and your ultrasound picture is the same way. You can compare, this is the bone, and we see the bony landmarks. When we now want to do a spinal or an epidural, we have to go to a slightly different transducer position. We have to go a little bit more lateral, then angulator transducer here against not scanning the articular pillars, but scanning the lamina here. Again, the volume where we have the transducer is this. And what you can see now, this is an MRI picture, this is the ultrasound picture in the longitudinal way along the spine. You see the laminas here and then interlaminar, the ligamentum flavum here, the dura, and then the anterior complex. That means you have the dorsal ligament, you have the anterior dura, and you have the vertebral body. And now what you can do for a spinal or for an epidural, you can go in directly. What I do usually to do an epidural in special cases, I do not directly. I mark the skin and I measure the distance. When I measure this distance, I know I can go in as deep as this, and then I have to be more careful and I can feel the loss of resistance, because I believe when we have the window where we can go in with the loss of resistance, we had a good technique to find epidural space, or when we do a spinal with the fluid coming back, the cerebrospinal fluid, another good tool that we are sure we are there. When we are going to the thoracic spine, it's a little bit more complicated, a little bit more different. This is a 3D reconstruction of a thoracic spine of a patient. You see what Bernhard Morigel told us before, that the spinal processes, usually they are not straight like in the models, they are rotated. And what you can see here, interlaminar, can you see a hole here? I can't, I see only bone. That means when you go back to the review article again, this transducer position, interlaminar, what you see there, you see the ligamentum flavum, you see the dorsal dura, but the window you have, or here, is much more narrow, because we have a larger overlap of the bone of the laminas. Thoracic spine, the same, you can scan it and you can see it. But here we have it to do with normal individuals. And now the question is, I thank to Bernhard Morigel, he gave me this picture. When you have a patient like this, can ultrasound help? You see, we have a total scoliosis. We can see from the back the intervertebral foramen. The vertebral column is rotated as much that the intervertebral foramen are lying not lateral, they are lying dorsal. Can ultrasound help? I tell you, yes, ultrasound can help you, but you have to know first the normal anatomy. When you start in these patients, you get crazy and you are very frustrated in the evening. I will show you another study from the group here in Toronto. Again, Dr. Chin, the main author, they were studying 120 patients with obesity, moderate to severe lumbar scoliosis, or previous lumbar spinal surgery. And they were trying to do spinal anesthesia with the landmark method or ultrasound imaging before the needle insertion. What they found is that they needed 6 minutes more time, but they had a better success rate. The number of passes for spinal needle insertion in the ultrasound group was lower. This is the graphic in the paper, and you see in this special patients, obese or scoliosis or after back surgery, the red group is the ultrasound group. 40 patients out of 60, they could find the spinal fluid came back in the first attempt. And you see, with the blind method, only half of the patient was possible. And of course, you see that they need more attempts in the not ultrasound guided groups. This is a nice study showing that ultrasound may help in difficult conditions. And again, the most important thing is you have to study first the normal anatomy in normal patients. When you want to use ultrasound for epidural or spinal procedures, do first scan skinny patients and patients you are sure you can go it with the landmark method. Longitudinal scan, again, ligamentum flavum, dura, the dorsal part, then anterior complex, or when you have the transducer like this, spinous process, articulations here, facet joint, and here you have the intrathecal space. When you are very lucky, you have a patient like this, you see everything, you see the dura, you see the spinous process, you see the entering of the articulations, but these are not the patients you will find in your operation room, but you will succeed only when you learn this first. Thank you very much for your attention.